Hello. So today we're going to discuss a bit about mitral valve prolapse, and I'm going to continue with my presentations for the cardiology PACES. Um, so mitral valve prolapse, this is not very uncommon, and you can get the case of MEP in your PACES examination. I'll try to be very brief and to the point. So, first of all, obviously, um, we all are aware about how to do the cardiovascular examination. So, once you've done your cardiovascular examination, how you will present the case. So, first of all, you're going to comment on the pulse, and most of the time in mitral valve prolapse, pulse will be regular and of normal volume. JVP not typically raised in a MEP case. No thrills or heaves on palpation. And you may get findings only on auscultation, and when you do the auscultation and listen at the mitral area, you may hear a mid-systolic click at apex, and this will be followed by the late systolic murmur. Important thing in MEP is to pick this murmur, and once you were able to appreciate the click followed by the murmur, then you have your diagnosis. Patient will be usually young, no scars present, no JVP raised, pulse normal. Then there are certain maneuvers which can be done to confirm your diagnosis of MEP. Normally it is not done, but it's worth mentioning in the exams that I like to do some maneuvers, like the murmur of MEP is increased by the Walsall void by standing, and it decreases by the by squatting, and the patient is not in heart failure. So let's listen to the murmur of the MEP. So it will be something like this. It's audible in the mitral area. So you can appreciate in this that there is a click, and then we have a late systolic murmur. And this one can be differentiated from the mitral regurgitation, which is also a pansystolic murmur. But in mitral regurgitation, the first heart sound will be very soft, and you will not able to appreciate any first heart sound, and the murmur will be throughout the systolic. There will not be any click in mitral regurgitation. All right. So, what happens in mitral valve prolapse is mitral valve cusp is displaced into the left atrium during systole. Since it's a bit of a floppy valve actually. So how does mitral valve prolapse normally presents? The patients most of the time are asymptomatic. Patient can present sometimes with chest pain or syncope, maybe palpitations, mitral regurgitation, and very, very rarely it can be embolization or sudden death. So once you see when you go to the station or the cardio station, there are some clues which are written there for the introduction. Suppose they write, this young lady presented with palpitation, please do the cardiovascular examination. So you should think about young lady, and palpitations can be mitral valve prolapse. Similarly, if they say the patient got syncope and the patient is young, then we'll thinking about mitral valve prolapse. Obviously, if they say the scenario say that the patient is old, like 60 years old, having chest pain and syncope, then you'll be thinking more about aortic stenosis. What about the causes of mitral valve prolapse? So causes, first of all, is idiopathic. Mitral valve prolapse is associated with some connective tissue diseases like SLE, osteogenesis imperfecta, Ehlers-Danlos syndrome, or Marfan syndrome. Then the cardiac causes of mitral valve prolapse include atrial myxoma or post mitral valve surgery. Other cardiac causes include ischemic heart disease, cardiomyopathies, or myocarditis. And there are other causes. There will be congenital causes and rheumatic fever. So if the examiner asks you about the causes, so these are the main causes for the MVP. What about the investigations? The examiner may ask you how you investigate these patients. So you can say I'll start by doing the ECG, and on the ECG we'll be looking for the P mitrale. There may be left ventricular hypertrophy or TV inversion. This is followed by the chest X-ray. Chest X-ray may show left atrial enlargement. Then echocardiography, which will confirm the diagnosis. Obviously, there is posterior movement of cusp, left atrial or left ventricular enlargement. So these are the three main investigations we're going to do. And these are, in any cardiac case, you have to do the ECG, chest X-ray, and echo. So what about the treatment? Well, treatment is conservative. If the patient is asymptomatic, it's just incidental finding, we just observe the patient. Then we can divide the treatment into two groups, whether it's a medical or surgical. So medical treatment is mainly for the complications. If the patient got any arrhythmias, then we give antiarrhythmic. If the patient has any arrhythmias like atrial fibrillations, we may need to anticoagulate the patient. And for the palpitations, we can prescribe some beta blockers. Surgery, well, not really done, but obviously if there's severe regurgitation, then the surgery can be done. And obviously you're going to refer the patient to the cardiology, and then they will decide about what type of surgery is needed, whether it can be repaired or the mitral valve need to be replaced. So my dear doctors, this was all about mitral valve prolapse. And I think if you come across the case, just remember the murmur, remember the patient is young. On auscultation, if you got some click followed by the late systolic murmur, then this is mitral valve prolapse. Okay, thank you very much, and I will talk to you